Arun, we can start.
Okay, sir. Good morning, everyone. In today's discussion, I am going to talk about VILI, that is ventilation-induced lung injury, its evolution and causes, PEEP, how to set PEEP at bedside, and concept of driving pressure, transpulmonary pressure, stress and strain. Briefly about electrical impedance tomography, its working principles, how to use electrical impedance tomography to adjust optimal PEEP, and lastly about mechanical power, how to calculate mechanical power at bedside. This is the outline of today's discussion. So in acute ICU settings, connecting a patient to the mechanical ventilator support is quite common, but it comes with the price. So acute lung damage that develops during mechanical ventilation. So VILI is result from the interaction between what the ventilator delivers to the lung parenchyma and how the lung parenchyma accepts it. So causes for VILI, we can broadly divide it into three categories, that is ventilator generated, lung conditions, extra lung factors. Ventilator generated causes are pressure, volume, flow, respiratory rate. Lung conditions are lung edema, inhomogeneity, stress rises, cyclic collapse and decollapse. Extra lung factors are perfusion, pH, gas tensions, temperature. So this picture depicts evolution of VILI since its first description. So if you go back a few decades to the 1970s, most commonly used mode is volume control ventilation. And after connecting a patient to volume control ventilation, the time target was to keep PaCO2 within the normal range. And it was most commonly observed after connecting to the ventilator patients developing bilateral pneumothorax, subcutaneous emphysema, pneumonia, these kind of factors. And even those times the recommendation was after connecting to the ventilator prophylactically to place bilateral ICDs to prevent complications such as bilateral pneumothorax. This is because pressure, when we are targeting volume control, to achieve that volume, how much pressure it is requiring, and what is the pressure limit we should target for, were not defined during that time. This is until ARMA trial published in 2000, there is no clear idea. ARMA trial was published in 2000. Their patient population is ARDS, and intervention is low tidal volume, that is 6 ml per kg, and they compared with 12 ml per kg, that is conventional ventilator support during that time. And at the same time, they compared 50 centimeter H2O of P-plateau to less than 30 centimeter H2O of P-plateau. And outcome is they observed significant mortality reduction in intervention group. That is approximately 9% mortality reduction. Post ARMA trial publication, ARMA trial results, it become part of lung protective ventilation, that is low tidal volume and targeting P-plateau of less than 30 centimeter H2O. And PEEP, since Ashbag et al. First description about ARDS, this PEEP is applied as a to improve the lung oxygenation. At the same time, it is a lung protective measure also. Webb and Tierney in 1970, they did an experiment in rats. What they did is 13 to 35 minutes approximately, they ventilated rats with peak pressure of 45 centimeter of H2O. And after 13 to 35 minutes, they observed the rats' lung flooded with fluid, they developed pulmonary edema. And the same experiment they did with producing PEEP of 10 centimeter H2O. Here, the development of pulmonary edema and alveolar flooding is significantly reduced. This is indicative of PEEP has lung protective effect. And post ARMA trial, that is after 2000, from 2000 to 2010, open lung approach or open lung ventilation come into the picture. That is, first they compared high versus low PEEP. These are the landmark trials published during 2004 alveolar type published, and 2007 Louds and Express trial are published. What they did is they compared low PEEP versus high PEEP. Low PEEP is around 5 to 9 centimeters to high PEEP as much as possible with targeting P-plot of less than 30 centimeters H2O. And including individual trials and meta-analysis failed to show similar results, and recruitment manuals also were tried during the same time. That is, in first trial came ART. This trial actually they increased the PEEP of 15, 25, 45. Briefly, they increased with target of PEEP at less than 60 centimeter H2O, and with the target of driving pressure 15 centimeter H2O. Though it shown benefit in terms of hypoxemia, but they observed significant mortality in patients who underwent recruitment maneuvers. At the same time, complications like hypotension, barotrauma also observed. Post ART results, parallel study also doing the recruitment maneuver study, they prematurely terminated the recruitment of patients. So, based on these trials, can we say open lung approach or open lung ventilation is obsolete, or we shouldn't utilize nowadays? Means to date, there is no recommendation for or against of this open lung ventilation. This is still questionable. Next, individual PEEP titration. How to set PEEP for your patient. So if you see in the beginning, we were using PEEP tables. That is based on FaO2. We have to increase the PEEP according to the table what they recommended. This is easy to use, but PEEP tables doesn't take account of lung recruitability, and at the same time, individual response of PEEP patient to patient, it varies widely. That is the drawback with following PEEP tables. Next is oxygenation response. So increase the PEEP and observe the oxygen improved or not. If oxygenation is improving, that is indicative of reduction in the intrapulmonary shunt. On the other hand, with the increase in PEEP, that is causing increase in PaCO2, that is indicative of overdistension. In similar way, increase the PEEP and observe the improvement in compliance. If increase in PEEP causing better compliance, that is associated with better survival. Next is image guided PEEP titration. That is set the PEEP, increase the high PEEP and observe do the CT scan and compare between previous one how much aeration is improved. But this is practically very difficult. ARDS patients that the two requirement of high FaO2 and supports shifting patient to radiology suite is very difficult. Practically, it's not feasible. Alternately, we can use ultrasound guided image PEEP titration, but problem with ultrasound guided is it cannot identify over distension. Next, driving pressure, esophageal pressure, and electrical impedance tomography I will discuss in coming slides. So this is another parameter you can see and adjust your PEEP, that is stress index. Further, patient you should keep in volume control mode. Here you can see flow time scalar and pressure time scalar. Flow time scalar is constant. That means patient is in volume control ventilation. So if you are seeing pressure time scalar like a straight line, that is indicative of stress index is equal to 1. Here, there is no room for further, whatever PEEP is set, that you have to continue. This means if you are getting stress index of 1. If you are getting stress index less than 1, that is this convex upwards, there is still room for increase in PEEP. You can further increase the PEEP. And in case, if you are getting stress index greater than 1, if you are getting a shape like this, concave upwards, there is no further increase in PEEP. Next, driving pressure. Driving pressure is defined as P flat minus PEEP. So this is the respiratory system compliance formula, that is equal to tidal volume divided by driving pressure. We can rearrange this equation like this: delta P equal to tidal volume divided by respiratory system compliance. Amato et al. They studied among 9 RCTs they taken, and they observed among 3,500 odd patients previously enrolled and treated for ARDS, and a decrease in PEEP owing to changes in ventilator settings were strongly associated with the increased survival. But major drawback with driving pressure recommendation is you should target less than 15. if with your ventilator settings, if you are getting able to achieve or driving pressure is reducing, that is also associated with better survival. But major drawback is it won't take into account of PEEP. For example, your PEEP, you are ventilating with zero PEEP or 20 centimeter S2O, it doesn't take into account. That is the drawback with driving pressure. Next, transpulmonary pressure. So, what is transpulmonary pressure? What is the need of it? For example, airway pressure, if you are taking that, for example, we are targeting people out of less than 30 centimeters S2O, that actually it is giving distension pressure of lung and chest wall. But what we need is true disturbing pressure of the lung. Not when you are taking P airway pressure, it is a poor surrogate of true disturbing lung pressure. Particularly patients with morbid obesity, pregnancy, chest wall abnormalities like kyphoscoliosis, intra-abdominal hypertension. If you are going with P plat or P airway pressure, falsely it give higher descending pressure. Actually actual descending pressure may be low, that may lead to lung collapse. So further, to eliminate the chest wall component, we need transpulmonary pressure. That is actually transpulmonary pressure is equal to P alveolar pressure minus pleural pressure. And after connecting to the ventilator, what pressure we are delivering, that is helps to distend the patient lung. And this pleural pressure acts in opposite direction. So always your distending pressure or airway pressure should be higher than the pleural pressure. And for this, you need on esophageal catheter. That here you can see, here you can see this trachea, this is esophagus. In esophagus, mid esophagus, here balloon catheter is placed. We have to place like this. It is come as a standalone catheter or part of nasogastric tube also. So because P pleural pressure we cannot directly measure, so we are taking esophageal pressure as a surrogate of P pleural pressure, and your transpulmonary pressure is equal to P airway pressure minus P esophageal pressure. So recommendation, how much we have to target. For example, at the end of expiration, your PEEP should be, that means P airway pressure, that is equal to your PEEP. It should be more than this P esophageal pressure. So you have to target at end expiratory, it should be at least 0 to 10 centimeters S2, but definitely not less than 0, that is negative. That means your pleural pressure or esophageal pressure that is higher than the PEEP, that causes collapse. So you have to keep it in this range, 0 to 10. In case of end in inspiratory transpulmonary pressure, you have to maintain less than 20 to 25 centimeters S2O, and transpulmonary driving pressure less than 10 to 12 centimeters S2O to avoid over distension. And briefly about electrical impedance tomography, it is a non-invasive, radiation-free bedside monitoring tool that provides functional image of the lung. When current is passing through a tissue, it offers a resistance that we called as impedance. So here you can see patient is applied to electrical impedance tomography. It comes with a belt like this, and it contains electrodes, 16 electrodes, 32 electrodes also available. Here what applied is 16 electrode belt, so that we have to apply mid portion of the chest and it is connected to a monitor. After connecting this, known current is delivered through one pair of electrodes. For example, here electrode 1 and electrode 2 is delivering the current, and when it is passing through the tissue, this impedance change will be calculated by the remaining pairs of remaining all electrodes. Once it done, then this current will move to pass through next set of electrodes. That is, first it was passing through 1 and 2. Now it will pass through 2 and 3. Then again same thing will happen. The difference will be calculated by remaining electrodes. When this all 16 electrodes is completed, that means one cycle is done. After that, you will get a picture like this. So this is divided as a 4 areas: area 1, area 2, area 3. That you can see here as a ROI 1. ROI means region of interest 1, region of interest 2, 3, 4. And this is the total tidal volume 473. we are delivering, that is equal to 100%. And each area, how much it is contributing also we can see. That means we are getting both pictorial representation and numerical representation. This is another picture of the EIT, another panel you can see. Here actually total 3 panels will be there. That is panel A, panel B, panel C. This is a global impedance panel. Actually what they did here is, it is decrementally, they decrease the PEEP and check the alveolar distension and collapse at where it is happening. On the panel B, you can see orange color and white color. And here they mentioned CLHP and CLLP. CL means compliance high PEEP, CLLP means compliance low PEEP. So when your patient, you are reducing from PEEP of 24 to lesser PEEP. So what we want is, we don't want over distension. At the same time, we don't want collapse also. In between somewhere we need that we call as an optimal PEEP. That where we will get is where these two lines, this orange line and this white line, where these two are intersecting. That is the point where we can achieve the optimal PEEP. That is equal to your here in this case 14 is the optimal PEEP, where these two lines are intersecting. And also you can see numbers represented here in orange color and white color. Orange is 12% and that white is 13. This is representing in this PEEP of 14, over distension is 12% and collapse is 13%. In case at 24 PEEP, orange color is more, that is 34% of over distension, 0% of collapse. In case of this picture, here 20% of collapse and 0% of over distension. And this is giving that intersecting point. So for this patient, set a PEEP of 14. If you are going beyond 14, that will cause over distension. If you are going less than this, that will cause collapse. That is the interference of this picture. Then limitations of electrical impedance tomography. Patients with pacemakers or electrically active implants, we cannot use this. And the inaccurate patients with pleural effusion, it only measures the regional ventilation, because we are connecting a belt at the mid portion of chest, and this picture only it is giving, and that we are extrapolating to the global lung ventilation. That is another limitation. So next, coming to concept of stress and strain. Stress is defined. Stress is equal to specific lung elastance into strain. Specific lung elastance is the constant, and the strain is the ratio between the change in volume and FRC. We can write it as like stress. This stress is corresponds to, in ventilator terms, equal to transpulmonary pressure. That is equal to specific elastance multiplied by strain, that is tidal volume divided by FRC. So stress means the force what we are applying to the lung, that is called as a force or stress. That is the force applied to the lung is the transpulmonary pressure that represents the stress experienced by the lung. And because of this force, what is the deformation happened to the lung is termed as lung strain. That is equal to change in tidal volume to the end expiratory lung volume. So here we can divide it as a dynamic strain, static strain, and global strain. Dynamic strain is equal to tidal volume divided by FRC. Static strain is equal to V divided by FRC. That means after applying to the PEEP, what is the volume change? That is the V divided by FRC. For the same value of dynamic strain and static strain is more harmful than static strain. This is what in the beginning also I discussed. Webb and Tierney, they did an experiment in rats. After applying to PEEP, they observed less alveolar edema and pulmonary edema. That is, we can explain it better with these terms, because actually what happened is there, after applying to the PEEP, we are getting the static strain. Because of that static strain, it is compared to the dynamic strain, it's better one, and it's causes less harm. That is the reason for we are using PEEP as a lung protective measure also. Along with it improves oxygenation both. So Maid et al. Proposed this concept. So if some part of lung is collapsed, The surrounding areas will try to compensate that collapse region. These areas act as a stress risers. So if a lung region expands less than the neighboring regions, the neighboring regions are more strained to compensate for the non-expanding or less expanding region. So with this equation again, we can explain why in ARMA trial, low tidal volume ventilation, they observed better mortality, because when we are applying low tidal volume, the strain component what delivered to the patient is reduced, and volume trauma is associated with barotrauma also. By this equation, you can say if tidal volume is more, this is directly proportional to the PL, that is transpulmonary pressure or force applying to the lung. This is also increasing. So volume trauma is associated with barotrauma. And if you are reducing your tidal volume in ARMA trial, that's what they observed. The strain is reduced, so that mortality benefit also they observed. And next type of trauma is tidal atelectasis, that is a repetitive collapse, repetitive opening and closing of alveoli. That causes extensive release of cytokines. Even when we are applying PEEP, they observed compared to then higher tidal volume, lower tidal volume, this biotrauma or atelectic trauma also less. Stress and strain maldistribution will occur throughout inhomogeneous lung parenchyma. So now, so far we discussed about volume and pressure as a causative agents of Willi or volume trauma. At the same time, we shouldn't forget flow and respiratory rate. These are also components of Willi. And big one is lung is acts as a viscoelastic nature. And when patient is breathing at a rate of 15 breaths per minute, some another patient is breathing at rate of 30 breaths per minute. So when patient is taking breath at 30 breaths per minute, the strain delivering to that patient is larger than when patient is taking at 15 breaths per minute. So when we are setting ventilator settings, particularly in ARDS patients, after volume and pressure, like we are targeting low tidal volume and P plat of less than 30, driving pressure of less than 15. Don't forget about flow and respiratory parameters also. These components also important and plays major role in development of Willi. So, so far we know these are the factors which can cause ventilator factors which can cause Willi. That is pressure, volume, respiratory rate, and flow. So in 2016, Gattinoni et al. Proposed this mechanical power concept. They clubbed all these four factors in one equation. This is the equation they first proposed. Actually, this equation derived from the equation of motion. This is the equation of motion, that is pressure equal to respiratory system elastance into volume change plus areas resistance into flow plus PEEP. This component elastance into change in volume, the pressure needed to overcome the elastic forces, and this component, the pressure required to move the gas inside the respiratory system. And this is the pictorial representation of the mechanical power. This green color one is static component of the PEEP. This is the energy required for the baseline stretch of the fibers. This is elastic component, and this is the resistive component. So already shown this equation. This is quite complicated, and this is difficult to use at bedside. So these are the simplified equations which derived from the original one. Suppose if your patient is in volume control mode, this is the equation we have to use to calculate mechanical power, that is 0.098. This 0.098 is the conversion factor from liters centimeter S2 to the joules. Joules is the mechanical power parameter. And respiratory rate into tidal volume, that is your minute ventilation. Peak inspiratory pressure minus half P plat minus P. This is nothing but your driving pressure. In case if your patient is in pressure control ventilation, this equation slightly changes. Same conversion factor, minute ventilation, P plus delta P inspiration. For your understanding, I kept one example here. For example, your patient is in volume control mode and predicted body weight of 80, and we are giving a low tidal volume, that is 6. That's so set tidal volume is 480. Here delta P, that means P flat of 21 and P of 8. Here delta P is 13 centimeter S2O. This is the formula for mechanical power, that is P peak minus half driving pressure minute ventilation into 0.098. For calculation purpose, we made it as here 0.1. So 34 is the P peak here, minus half, that is 0.5. Driving pressure is 13 multiplied by 12, that is minute ventilation. Here 11.9 is there, here taken it as a 12, and 0.098 taken as 0.1. If you calculate this, you are getting 32 joules per minute. That is this patient's mechanical power, what we are getting. So what evidence says? So in 2016, Gattiano et al. They given this concept of mechanical power. After that, in 2018, 19, 20, these are the studies came. These are all retrospective studies. They observed if patient mechanical power below this range, that is 17 to 22, below this range, that is associated with better survival. If it is more than this, that is associated with higher mortality rate. So in our patients now, mechanical power is 33. So what we can do at bedside? So these are the parameter you have to adjust. For example, if your patient is breathing at 25 breaths per minute and your ABG is relatively okay, then reduce your respiratory rate. Try to bring your mechanical power to the this range, below this range. But mechanical power here only they whatever evidence we have, that is we got from the predominantly from retrospective studies. Till date there are no large prospective studies available. That is first limitation. Second is, we know these are the parameters which can cause VILI and we have to adjust. But for which component I should give more importance? First, which parameter I have to target? After, which parameter I have to target? If someone is asking these questions, questions are at present there is no answer. So what we know so far is that these components like pressure, volume, flow, respiratory rate, these are the causative agents of VILI. We should be more careful in adjusting these parameters. And after setting the patient, after connecting the mechanical ventilator, after setting that low tidal volume and achieving driving pressure P flat, you just take next step forward and calculate the mechanical power also, and see what is the mechanical power of your patient, and try to adjust your parameter, and then again you check the mechanical power whether you are able to reduce that, bring back to normal level or not. So but these questions are unanswerable yet. That's which parameter I should give more importance, and these are all data available from the retrospective studies. So these are my references. I will stop here, and if any doubts, you can ask.
Thank you, Arun. I think you have highlighted a lot of important concepts in a very, very simplified way. Mechanical ventilation over the last few years has become much more objective, with the ability to look at the different aspects of ventilation in this lung injury at the bedside. Today, there are a lot of parameters which can be easily assessed and measured, and which can help us actually deliver safer ventilation to patients who are admitted to the intensive care unit. Okay. So I don't have anything more to add. I think you have explained most of the concepts in a very, very simplified way. Srinivas, anything that you want to add?
Thank you, sir.
Srinivas, Runara?
Yeah. Thanks, Arun. I think it was very informative and crisp talk. The mechanical ventilation, when we started learning, was thought of very.
Srinivas, we are losing you.
Was thought
Srinivas, we cannot hear you.
Can you hear me?
Yes, sir.
Yeah, now.
So when we started learning mechanical ventilation 25 years ago, it was a very intimidating and complex thing. We did not know what we were monitoring, how to wean patients. From then on, some method came in after the ArtsNet told us about tidal volume, speed, a little bit of resistance and compliance. But I think the game changers in the way we manage patients, the game changers in the way we actually do personalized ventilator settings has been the recognition of driving pressure as an important player in the whole process. That has made it a very simple tool to decide when to prone patients, when to put them on ECMO. We have a definite number beyond which we don't try any more ventilatory strategies. We go for extracorporeal techniques. The other game changer is mechanical power. Now, power, we all understood from the COVID pandemic that patient self-induced lung injury is a real entity, and it has always been a phenomenon, but probably we didn't realize it. And there, the mechanical power is something that is a contributing factor, and the respiratory rates at which we ventilate patients is an important determinant of that ergo trauma that happens to these patients. We were always taught that you should match the patient's minute ventilation requirements when you ventilate patients. And in that anxiety, we have ventilated patients with respiratory rates of 30, 35. Even today, with under the permissive hypercapnia thing, we put rates of 30, 35. Is that really good for the patients? We are not sure. So at this point of time, a combination of driving pressure, mechanical power, combined with assessment of electrical impedance tomography and extrapolation with lung ultrasound, I think we can make with mechanical ventilation very smooth and safe for patients. So from the era of just lung protective ventilatory strategy, we have progressed to diaphragm protective ventilatory strategy, and now we have come to a right ventricular protective ventilatory strategy by a combination of all these factors. So thank you, Arun. I think you simplified these concepts. We'll meet again next week with another topic. In the meantime, those who have not registered for the HICS, please do register for the program. Several such interesting path-breaking topics. It has been a tradition of HICS to bring in latest advances into your midst, and we are again doing it on the 10th, 11th, and 12th of May. Please do join us before you exercise your right to vote on the 13th of May in Telangana. Thank you very much and have a good day.
Thank you so much, sir.